Many other therapies exist to kind of palliate and make you feel better. Some people like a heating pad on their back. Some people like a cold pack. Some people like counter pressure with a tennis ball or massage. So laboring in the tub. There are many, many different ways that we get through the initial phases of labor and sometimes the entire labor using these methodologies. Okay, so of our patients, about 2/3 have a labor epidural. Statistically in the U.S., it is something like 93%. I don't know why Madison is so rare, but Madison in general is about 1/3. So we have a little higher statistic of patients that are electing labor epidurals compared to Madison, but a lower statistic compared nationally. 14% patients choose narcotics alone, and we'll talk a little bit about the narcotic that is traditionally used for labor management. About 1 in 5 women don't use any medication to deliver. So it's possible if that is your choice. So let's talk about narcotics. The most common medicine that is provided to women, actually in the Madison area, is Numorphan. It is a short-acting narcotic. It lasts about 2 hours, and I think it takes the edge off of the contractions. You will still feel those contractions, but then what I notice is patients then begin to relax as the contraction dissipates and they rest in between. Like any narcotic, I think it can cause drowsiness. The third bullet point I'll comment about, it may cause reversible depression in the newborn. What we mean by that is respiratory depression, so we don't mean it makes your baby sad. It means your baby just doesn't have a drive to breathe. So one of the ways to decide if you are a Numorphan or narcotic candidate is, well, how dilated are you? If this is your first baby and you're 10 centimeters and you've been pushing for an hour, probably not going to give you another Numorphan dose. If you have had 4 children and you are 8 centimeters and seem to be going quite quickly, probably not another Numorphan dose, because we would expect you to be delivered within that 2 hours. Realize, however, in the event things happen, we think it's going to be a long time, we give you Numorphan, and 30 minutes later you're delivering. If the baby has respiratory depression, there is a medicine that is given to your child called Narcan that binds the Numorphan instantly and removes it from its bloodstream. So it is reversible, as a point that I'm trying to make. So you try to make good decisions. Of course, labor is not truly predictable, but for the most part, even if you receive that Numorphan too close to the time of delivery, we can take care of it. I also think narcotics, as well as some other pharmacological options, may slow your contraction, either intensity or frequency. So it's something to think about if you're early in labor, that we don't want to give Numorphan too soon. So we want you to be clearly established in dilating your cervix so that we don't slow the labor. Now we're back in the beginning where things really haven't taken off. So let's talk about epidural. That 67% of our patients elect. What is it? It's an anesthetic that is placed through a very thin, pliant, hollow tube in the back by an anesthesiologist in the epidural space. So it bathes your spinal cord from a certain level down in this medicine. There's not a needle left in your back. It's extremely effective for pain relief. What women will comment, a good epidural is they'll still have some motor function. They'll be able to move their legs a little bit. But they do not have back pain or pain affiliated with contraction. They will notice pressure, and actually that's okay. Some people are really bothered by that, but you cannot remove that sensation with an epidural. But the reason why I think it's a positive is that when it comes to push, if you have no perception of discomfort or when your contraction's occurring, it's kind of nice to know, oh, I'm feeling this pressure, now it's time for us to begin pushing. Again, it may also slow contractions. It does decrease your urge to push if you've not had, if you don't have that pressure sensation. You do need an IV in that we need to hydrate you prior to the epidural, and you will be monitored. You're not going to be up and moving around. You can move in the bed, and we encourage you to move from side to side in the bed, but you're not up and walking. And that also means you don't know your bladder's full. So we will drain your bladder once the epidural is in place. A Foley catheter will be placed to drain your bladder. It's removed when you begin to push so that you're not feeling that removal as well. But that's an important aspect of the epidural. And this is just an example of where's the area that's numbed. And the anesthesiologist will place a needle essentially at this point that the anesthetic is a very dense anesthetic, so it's gravity dependent and it will fill and bathe this space, and that creates the numbness. So it's not numbing it above. And you'll also see them test your levels with an ice glove filled with ice, to discern if you're, where your level is. Okay, so they'll be testing you to make sure that they're getting you adequate relief. And we put this picture in there just to kind of demonstrate that it's a hollow needle. The catheter is thread through that needle, and then the needle is retracted over the catheter, so there's no sharp left in your back. And then that catheter is taped to your back, so it's immobile until you've delivered, and then we remove the catheter itself.